How does a hospital get upside down on a specialty pharmacy? I mean, like, what causes a negative reimbursement or a low margin?
That's a great question. Actually, one of the easiest ways is not paying attention to the 340B status of a particular dispense. So, especially if you're a disproportionate share hospital, a DISH hospital, you're subject to the GPO prohibition. And as such, you would be hit with purchasing the drug at WAC rather than on a 340B account if it doesn't qualify. So that's another way that we partner and we make sure that every prescription that should be eligible is deemed eligible in the processor so that they're not upside down in a pharmacy dispense.
So what do you do if you get sent a drug and you don't have access to that PBM yet? I mean, how do you handle that?
Yeah, I mean, you really don't want that to happen because that means you're going to need to send your patient somewhere else to fill their prescription, which that can happen. But one of the things that we do is we make sure when we go in for the specialty pharmacy project at a health system is understand who the payers are in that area, in that community, so that we can go ahead and address that on the front end and get access to that network. So we work through that, navigate through it, reporting all the requirements, as Lauren mentioned before. We make sure all that's done, and so our goal is to take care of every patient.
So talk to me about getting a prior authorization. I mean, assuming most of these drugs require prior authorization, what type of time is spent doing that? What's the burden on a facility to do that?
Well, and that's the thing about specialty pharmacies because it's so high cost. Many PBMs will not pay for it just out of the gate. So there are a lot of hurdles you have to get through with the payer to get the drug covered. And then even once it's covered, the copay can be really high. It could be thousands of dollars. So most of the time patients can't afford a copay that high. And so what we do is we search for copay assistance. There are manufacturer programs, there are other assistance programs.
Yeah, third-party programs
Third-party
out there.
programs, right.
Charities.
Charity care. We search for all of those and make sure that, just within a few days, it's usually, 2-day turnaround and the drug is on its way to the patient.
And that's another benefit of having a pharmacist embedded in the clinic that the patients are in, because that pharmacist in that clinic is able to provide that assistance before they even get to the specialty pharmacy. So they are able to look for financial assistance. They're able to perform those prior authorizations, making sure that it's going to be paid for and that the patient is going to be able to afford it even before the patient gets to the specialty pharmacy, has a conversation with the pharmacist that's dispensing the drug. It's already taken care of. So once it gets to the specialty pharmacy, we're going to be able to fill it because we've done all of that on the front end in the clinic setting.
Great, and I'm assuming from the patient, there's no surprise bill. They understand how this is going to get paid. And the people that are taking these drugs are generally your sickest people, right? I mean, that's what a specialty drug is. It's people with cancer, MS, etc. And we don't want them worried about their bill.
That's correct.